Good day, students. I am Dr. Lisa Kalimag. Today, I will be lecturing on the biopsychosocial paradigm of care, as well as the patient-centered, family-focused, and community-oriented model of care. At the end of the session, the students shall be able to differentiate the biomedical model and the biopsychosocial model, identify biological, psychological, and social factors that influence health, and apply the biopsychosocial approach to the holistic care of a patient and his or her family and community. That is what we call patient-centered, family-focused, community-oriented healthcare. So first, let us discuss the traditional medical model, which is the biomedical model. The biomedical model is rooted in medical practice 4 centuries ago, when physicians were allowed to dissect the human body. The biomedical model believed that understanding a complex entity can be achieved by analyzing its component parts. They would study the human body and its components using physics and chemistry. The person or the human body is a complex entity. This can be divided into the organ systems, which are then divided into organs, followed by tissues and cells, and so on. The biomedical model seeks to understand the human body using this framework in order to keep the patients healthy. But what is healthy and how do you define health? So let's review this definition according to the World Health Organization. Health is defined as the highest possible level or state of complete physical, mental, and social well-being, and not merely the absence of disease. There are other definitions of health, but for this lecture, please keep in mind this definition. Now we move forward from the biomedical model to the biopsychosocial model, which was proposed by the psychiatrist Dr. George Engel. This model says that neither disease nor illness is understandable only in terms of smaller and smaller biological components. A person's response to a disease requires consideration of factors such as the social and cultural environment, the individual psychological resources, and the biochemistry and genetics of the disorder in the population. This model emphasizes the unity of the body, mind, and social context. You can then analyze patients not just in terms of their component parts, but through this macro scale from the biosphere to the society, community, and family. The biopsychosocial approach does not attempt to replace the traditional way of approaching medicine, but tries to go further by taking a whole person approach, that is, a holistic approach, to manage patients and their various medical conditions. In the next slides, we will be discussing the biological factors, psychological factors, and social factors affecting health. Biological factors include demographic profiles such as age, sex, marital status and parity, race, and occupation. Biological factors also include genetic characteristics, environmental characteristics, and lifestyle characteristics. As an example, under demographic profile, we know that having the following characteristics are associated with reduced mortality from nearly all diseases. This includes female sex, marital status, being married, higher socioeconomic status, and greater number of social ties. As for age, we know that older age is associated with the following diseases: hypertension, diabetes, coronary artery disease, chronic kidney disease, and most cancers. However, in younger age, they are more likely to have streptococcal throat infection, many infectious diseases, hence we have the expanded program of immunization, and certain types of leukemia. For sex or gender, we know that there are diseases that are associated with menopause, such as cardiovascular disease and osteoporosis. Of course, we have the obvious fact that men can have prostate cancer, while women can have breast cancer. So this is why you should have different or varied screening programs for each sex. For parity, nulliparity or never having given birth is associated with increased risk of breast cancer. For the opposite end of the spectrum, which is having too many births, 5 or more, this is called grand multiparity, and there are some studies that they are associated with adverse maternal outcomes. However, it may also just be due to their older age. Of course, we have genetic characteristics that predispose to certain diseases. We have these congenital diseases, among others, in the Philippines, hence the importance of the newborn screening program in order to facilitate early interventions. So we have congenital hypothyroidism, congenital adrenal hyperplasia, galactosemia, phenylketonuria, and homocystinuria included in the newborn screening. Finally, we have lifestyle characteristics such as the following, which predispose to various diseases. This includes alcoholism, substance use and abuse, smoking, lack of exercise and physical activity, and overnutrition or undernutrition. Moving on to psychological factors, this is composed of the affective or feelings, cognitive or beliefs and expectations, and the behavioral dimensions. Patients' defense mechanisms and coping styles also influence their health and illness. The health beliefs of people influence their health-seeking behavior. So we should identify the health beliefs of patients, correct any existing misperception regarding their illness, and improve behavior. For example, you still hear some patients say that they don't want to take their medications as much as possible because they believe that yung mga gamot makakasira ng kidney, and that herbal medications are safer because they are natural. These patients may consult a doctor late, or even if you prescribe them medications, they may not want to take their medications. So you have to correct their misperception about the safe doses of medicines, which have been studied in clinical trials, and maybe they had misunderstood about the renal dose of drugs, which is when the patient already has kidney disease. You need to lower the dose of the drug, or some drugs are not allowed to be given when the patient has kidney disease. But that doesn't mean that the drugs themselves cause kidney disease, because we would not be giving those medications. Filipinos have many traditional beliefs about healing, such as these mentioned. For my discipline, which is family medicine, we do not belittle nor mock these beliefs. We respect them, but we emphasize the evidence-based medicine, and they can add on the alternative medicine if they wish, as long as it doesn't obviously cause them harm. Personally, I warn them most about the lack of studies on herbal medicine, because that's oral intake. So that's for me the least safe, or the most likely to have side effects or ill effects on them. However, Filipinos may feel comforted by practicing these traditional beliefs. It could remind them of their province, of their home, their community, how their mother took care of them when they were sick. So it could improve their well-being. These are other examples. Okay, so how do you address psychological problems brought about by misperceptions of patients about their disease? We can do primary care counseling, which is a face-to-face psychoeducation method. It brings out the psychological concerns that result from a misperception of reality that hinders appropriate behavior. This is what we call emotionally critical misperceptions, or ECMs. If ECMs are addressed appropriately, barriers are lifted and educational inputs are better received. So the example I gave earlier of a patient believing that medicines cause kidney damage is an example of an ECM. Okay, so there are methods. These methods are derived from Carl Rogers' person-centered psychotherapy. These are forms of primary care counseling. So primary care counseling can be through CEA, which is Catharsis, Education and Action, or CIA counseling, which is Catharsis, Insight and Action. So this is what you do. In Catharsis, you first ask for the patient's thoughts, feelings, and fears about their illness. Then you identify the emotionally critical misperception. Then you either educate the patient or they get the insight on their own. So that's the insight part in CIA. And then for the action, together you create an action plan on the behaviors that will be corrected by the patient. So what's important about the catharsis part? Why can't you just go directly to education? So what's good about the catharsis is it helps the patient unload their fears, their emotions. Some people can be very strong with their beliefs. So the catharsis helps to release those fears. And when they see that you are listening without judgment, then they will be more likely to believe you when you start educating them. Aside from that, the catharsis helps you to accurately identify what is their emotionally critical misperception. Because sometimes we think this is their misperception, but it's actually something else or some other aspect. Um, or yeah, yeah. So in this method, it is important for the counselor to show genuineness, unconditional positive regard, and empathy. Unconditional positive regard means you let go of all of your judgments towards the patient, even if they have wrong beliefs, and you look at them in a positive light or you see the best in them. However, if you show judgment towards the patients, the counseling will not be effective. The counselor should also employ active listening skills such as nonverbal cues to the patient to let the patient know that you are listening. Okay. We will now move on to social factors, primarily regarding the family. I will be introducing you to the concepts of family structure, family assessment tools, family life cycle, as well as the impact of illness and illness trajectory. These social factors affect the quality of life of individuals. Why do we give attention or importance to family? The WHO recognizes the family as the primary social agent in the promotion of health and well-being, as well as disease prevention. The family influences a person's beliefs and health-related behaviors. So it's common for health beliefs and behaviors to be shared across the family, whether these are positive or negative. For example, when do you go to see a doctor, diet and exercise is practiced. These are commonly shared among the family. The family can also be a source of stress and emotional support. The classical definition of family is that of biological and marital kinship, along with patterns of reciprocal obligations. So basically, you are biologically related or married, and you take care of each other. But the emphasis is on the biological and procreative relationships, as well as the child rearing structure. This is the classical definition. The modern definition, in contrast, is a small social system made up of individuals related to each other by reason of strong reciprocal affections and loyalties, and comprising a permanent household that persists over years and decades. So it's a more flexible definition that includes same-sex couples with children, unmarried couples with children, couples with stepchildren, and single parents with children. We can describe a family in terms of family structure. So for nuclear family, you have the parents and their dependent children. For extended family, this includes three generations. You have the grandparents, parents, and children in one household. It can be unilateral, so one side lang of the family, like on the husband side or the wife side, or it can be bilateral, so both husband and wife mayroong grandparent living with them. A blended family includes step-parents and stepchildren, and you also have single-parent family. Here are some clinical correlates. Being a single parent is associated with higher death rates due to cardiovascular diseases, malignancies, infectious diseases, accidents, homicides, and suicides. Whereas being widowed is associated with 4 times higher age-specific death rates compared to married individuals. For divorced men, they have increased rates of depression, suicides, and domestic violence. Then for stepchildren or children of single parents, they are associated with developmental delays such as autism spectrum disorder, attention deficit hyperreactive disorder, depression, and adjustment disorders. So these are the family assessment tools that we can use to study and describe the family. I will discuss each one briefly. These are actually what family physicians do or study during residency, when we want to focus on a particular family with particular familial problems. So the first assessment tool is the family genogram or family tree. Here are some of the symbols that we can use to describe the family and its members. So we have squares for males. We have squares for males and circles for females, an X mark for death. We also have symbols denoting marriage and divorce. And most importantly, in the genogram, you should create symbols for the diseases, especially hereditary diseases in the family. I'll show you an example. So note the diseases that run in this family. You have stroke, hypertension. This is the index patient, the one with the arrow. So he has hypertension and Parkinson's disease and kidney disease. So knowing these illnesses that are present in the family, we would probably need to screen the children of this index patient for hypertension and other metabolic diseases due to their family history. The genogram gives you an overview of the family. So you can see here they are a blended family. This is the married couple. They both have previous spouses or partners prior to this current um, partnership or marriage. Okay. So this genogram can help us identify allies in health that can help take care of this index patient. The next family assessment tool is the family APGAR, which assesses family function. APGAR stands for adaptation, partnership, growth, affection, and resolve. So adaptation means the family's utilization of the resources available within and outside of the familial system when significant life events pose a crisis. So for example, somebody got hospitalized. Is the family able to adapt by collecting finances to support the family member or assigning a caregiver to take care of the sick family member? And then partnership is the sharing of the family members in decision making and responsibilities. So hindi yung isang person lang yung nag-decide, kundi it's a joint decision making. Then growth is physical and emotional growth attained by each family member from the family's ability to support and guide. So each family member should not be stagnant, but instead they should be supported by the family in their growth. For affection, this reflects the satisfaction with emotional relationships and intimacy within the family. And for resolve, this is the commitment of family members to devote time to support each other's physical and emotional growth. It also pertains to the sharing of wealth and space. So this is how you would ask the APGAR to a patient. So yeah, let's just go through it quickly. For adaptation, I am satisfied that I can turn to my family for help when something is troubling me. For partnership, I am satisfied with the way my family talks on things with me and shares problems with me. For growth, I am satisfied that my family accepts and supports my wishes to take on new activities or directions. For affection, I am satisfied with the way my family expresses affection and responds to my emotions such as anger, sorrow, and love. For resolve, which is like commitment, I am satisfied with the way my family and I share time together. So, okay, so that's a glimpse of the family APGAR. Next, going to the family map, this pertains to how you describe the relationships between family members as well as the boundaries between each member. So it could be either rigid boundaries, clear boundaries, which is good, or diffuse boundaries. Then you can also have coalitions between members against another family member, can show conflict between members, detouring, and over-involvement or enmeshment. Next assessment tool is the family SCREAM. This stands for social, cultural, religious, economic, educational, and medical. So this represents the family resources in these specific aspects. This assessment tool is commonly used when the need for care is long, such as in chronically or terminally ill patients. So, for example, social resources could be your neighbors, your community, um, any people who could be willing to donate finances or um, acts of service, to help the family. So, cultural could be the cultural beliefs that, um, for example, bayanihan. Then for religious could be their specific religious beliefs, which help them to cope with their illness, or the religious institutions like their church that may also help them to cope with the illness. And then for economic, that's of course there's the state of their finances. Then for educational, it's what they have studied or what they have graduated, so like college graduate or high school graduate. But it actually means how well they are able to understand their illness and how well they are able to understand the things they need to do to to manage their illness. And then for the medical resources, those are the nearby hospitals, clinics, specialists, primary care physicians, etc., that the patient has access to. Then for the family lifeline, this summarizes the individual or the family's significant experiences in a chronologically sequenced manner. It also includes how the family has coped with these stressful life events. So this is an example from the manual. In a patient that has been suffering from chronic headache, it was noted that certain life stressors exacerbated the headache. In this patient, the highest severity of headache was with academic and work-related problems, as well as marital problems. So another aspect of studying families is the family life cycle. The family life cycle shows the evolution of the marital relationship and presents cyclic development of the evolving family unit. This shows the ability of the family to transcend the emotional process of transition, where the key element is adaptation. So every time they go from one um, stage to another, they have to fulfill that transition or adaptation. So this is the six-stage family life cycle. We have unattached young adult, newly married couple, family with young children, family with adolescents, launching family, and family in later years. So first, there is an unattached young adult. When a person leaves their family of origin to live by themselves independently. So that could be most of you listening to this lecture. The young adult has to come to terms with the family of origin and is formulating personal goals in developing as an individual, including forming a new family. So the key principle is accepting your separation from your parents, your independence, and accepting financial and emotional responsibility for oneself. When the young adult gets married, they move to the next stage and form a family unit with their spouse to be the newly married couple. So the key principle here is commitment to the new system, commitment to your spouse, and differentiation from your family of origin, and making room for your spouse in among your family and friends. So once the married couple has children, they will again need to adapt to the responsibilities of this stage, primarily adjusting to parenting. This stage is called family with young children. So this starts with the pregnancy for the first child to emergence of adolescence. So here, what is notable is the new roles from wife to mother and from husband to father. There could be conflict with home and school regulations. And the key principle here is accepting new members into the system. So new members, of course, is the young children. Accepting your new role as a parent and your responsibilities. And then for family with adolescents, so when their children grow up to be teenagers, that will then be the stage called family with adolescents. Because teenagers have different needs as compared to young children, they need more independence. So this is a unique stage. The key principle is increasing flexibility of boundaries to include children's independence and grandparents' frailties. So when a married couple has teenage children, their parents are usually older, so they're getting sick at that stage, so they have to take care as well of their parents. Now next is launching family. Once the original married couple's eldest child grows further into adults and eventually leaves the nest, the original couple is now in the launching family stage. So the one who left the family will start their own life cycle as an unattached young adult. And this stage ends when the last child leaves home and the launched children start their own families. So the key principle is accepting a multitude of entries into and exits from the family system. So yung entries into, for example, yung in-laws, son-in-law, daughter-in-law, um, mga manugang, ganyan. And then, the exits from the family system could be the elderly parents of the original couple who may pass away. Once the original married couple has launched all their children, they are now a family in later years. At this stage, they should be preparing for death and bereavement. The key principle is accepting the shifting of generational goals. That is when you are an elderly couple, you turn over the authority, being the head of the family, being the decision maker to your adult kids because of your increasing frailty. So that is the family life cycle. There is also what we call the illness trajectory and the impact of illness on the patient and the family. The knowledge of the trajectory allows the primary care physician to predict, anticipate, and deal with the family's response to the illness and eventually enables the physician to formulate individualized therapeutic plans. These are the stages of illness trajectory. We have onset of illness, impact phase, or reaction to diagnosis, major therapeutic efforts, recovery phase, and adjustment to permanency of outcome. So first you have the onset of illness when the patient starts to feel any symptoms, but they haven't consulted a doctor yet. That is onset of illness to diagnosis. For example, a patient has constipation and rectal bleeding for 1 month. No checkup yet. Okay, so at this stage, medical beliefs and previous experiences influence the meaning of illness. They frequently just ask their family, their friends, what could be the meaning of this? Am I sick? Ganyan. When they consult a doctor and get diagnosed, they go to the impact phase or reaction to diagnosis phase. So they get diagnosed, for example, the patient with rectal bleeding and constipation got diagnosed, unfortunately, with colorectal cancer. And this phase is where they have to deal with all the anguish and turmoil of the diagnosis. So in the emotional plane, you have all of these possible emotions. And then for the cognitive plane, you start off with confusion, um, spreading denial, and then starting to go towards acceptance. The next stage is major therapeutic efforts. So this stage, The patient, with the help of their family, is focused on the treatments, for example, surgery, chemotherapy, other medications. Here are some critical issues in choosing the therapeutic plan. These are things we can consider when talking to the patient on deciding, for example, are you going to do surgery? Are you ready to do chemotherapy or palliative care? Are you going to hospitalize the patient versus going to do home care? You have to consider these. So the psychological and preparedness state of the patient and family, assumption of responsibility for care and responsibilities of each party, economy of the therapeutic plan, lifestyle and cultural characteristics of a family. Okay. And then the fourth phase is recovery phase or early adjustment to outcome. So after therapeutic efforts, the patient either recovers and goes to the recovery phase, or they have a bad outcome such as disability, or they could be bedridden. Now the family will have to support the patient in that outcome. And the last stage in the trajectory of illness is adjustment to the permanency of the outcome, whether that is death of the patient or permanent disability. Unwillingness to accept the outcome may be a sign of pathology. There is such a thing as prolonged grief disorder, where family members have a difficulty in accepting the death or moving on from the death of a family member or a loved one. So that can be something that we watch out for. The difficulty in adjustment can vary depending on whether the illness was acute, chronic, or terminal. In acute illness, there is a potential for crisis when family routine is suspended. So, for example, the patient who died is the breadwinner of the family. So now the family is at a loss on what to do next. So, who will provide for for the family? Emotions are high and can lead to anger, especially if medical care is perceived to be inadequate. For example, a patient died during childbirth, for example, from eclampsia. So that is very much not expected by the family as an outcome for childbirth. So it would be very difficult for them to deal with that, and there can be some blaming, no, blaming towards the medical workers who manage the patient. And we have to be more empathetic of what they are going through, or we can anticipate that they will have these emotions. In chronic illness, there is prolonged fear and anxiety, which can cause higher incidence of illness in other members of the family. This highlights the importance of preventive and screening measures among members of the family to detect early onset of illness. So sometimes yung caregivers, sila naman yung nagkakasakit, no? So we also have to take care of them. Chronic illness brings about additional burden, feelings of guilt, especially if the patient was previously neglected. So may mga guilt feelings pa yan minsan sa mga caregivers when the patient dies. In terminal illness, such as cancer, the initial response is of shock and overwhelming anxiety. It is highly emotional and devastating. The grief reaction, if in a functional family, the family members can draw closer to each other. That's good. But if dysfunctional, it can be a seed for family discord and breakdown. So we can aid in efficient and functional readjustment and provide quality care. Usually, home care is best, for the comfort of the patient. So there is a field of medicine, which is hospice and palliative medicine, which focuses on providing support and care for terminally ill patients as well as their families. The goal is not anymore to cure them, but for them to live as fully and as comfortable as possible in the time remaining. We also want them to attain a degree of mental and spiritual preparation for death. Some of the ways to do this is through discussing their advanced directives and who will be their surrogate decision makers when the time comes that they cannot decide on their own. So how do we summarize the biopsychosocial approach In our discipline, that's family medicine, we use the PFC approach. PFC stands for patient-centered, family-focused, community-oriented care. In this slide, let's look at patient-centered healthcare. So of course, you have history and physical exam. That's the medical component. We add to that as asking about the patient's fears, doubts, concerns, and predicaments. For analysis, we come up with the primary working impression and differential diagnosis. But we also identify the stage of the trajectory of illness and the impact of illness. For plan of management, we order diagnostics, we treat the patient pharmacologically and also non-pharmacologically, such as health education and counseling. For the family-focused healthcare, we look at the family determinants and resources. We look for possible caregiver issues. We analyze with the family assessment tools, family life cycle and impact of illness. For management, we can do capability building of caregivers, health education for the family, and family counseling. So lastly, we have the community-oriented healthcare. I didn't really discuss this during this lecture because it's too broad. You will be having more lectures, especially in your third year when you have community medicine for these topics. But as an introduction, we should look at the home and work environment, such as sanitation, the social determinants for health, the building blocks of health systems, health laws, epidemiologic data, such as what diseases are prevalent in the community, and then summarize this into the enablers and barriers to care. And for the plan of management, we manage to the patient by referring or linking the patient to services that can help, such as PhilHealth, DSWD, senior citizens organizations, community exercise programs, etc. We strive for an interprofessional and multidisciplinary team approach to promoting health and well-being in the patient. This is my last slide. Thank you for listening and see you on our synchronous Q&A session.